It's a beautiful day outside, the sun is shining, and what better way to spend it than doing some board review questions. I hope you guys are doing well now that spring is upon us. Just a little quick update for you guys before we get started. I broke out my DDR pads again, and I've been starting to do some more DDR again, which has been really nice. I feel like I haven't exercised as much as I should have for quite a few months now. And then also, ever since I did that review of my sister-in-law doing the clinical problem solver case, I've been basically listening to the podcast every day while I'm driving to work. And it's kind of been very reinvigorating. I feel like every time I listen to a podcast, I just get a couple of key learning pearls each time. And it's really kind of reinvigorated my, interest in doing some more learning on my own. And honestly, it's been really good for my mood overall because I feel like when I'm actively learning things, I just feel more positive in general. Let me know in the comments down below what your favorite internal medicine podcasts are. I'm very curious to hear what you guys like to listen to. And let's get started with these board review questions. A 60-year-old woman presents to the emergency department for dizziness. This is her chest x-ray, and she has brittle hair and periorbital edema and swelling in the neck. Very interesting. Brittle hair and periorbital edema, swelling in the neck. That's starting to make me think a little bit of, this kind of combination of things kind of sounds like hypothyroidism to me. Initially, I was thinking with brittle hair, you could think of some vitamin deficiencies, like vitamin C deficiency or something. But come on, scurvy is super rare. But then you've got periorbital edema, and swelling in her neck, almost like a goiter potentially. But let's see what the actual answers are. What is the most appropriate test to establish the cause of the chest x-ray finding? What is the chest x-ray finding? I see kind of like an enlarged heart here, and it's almost water bottle shaped. So it almost looks like it could be suggestive of a pericardial effusion, to be honest. Her airway appears midline, although maybe a little bit of deviation here once you get to the carina, but otherwise looks okay. Nothing in the lung fields, and the diaphragms look relatively normal as well. You lose a little bit of it here, so you can't really see too much here. So a serum thyroid stimulating hormone test, an EKG, pericardial biopsy, dexamethasone suppression test, or VQ scan. So VQ scan, if we think a PE, but this is not, you're not going to find a PE on a chest x-ray. We learned about that Westermarck sign and Hampton's hump sign, but I've never seen any of that. That's like very rare. Dexamethasone suppression test would be for hypercortisolism or Cushing's disease, which they're kind of considering with the swelling in the neck and everything, but I don't think it's that. Definitely would not jump straight to a pericardial biopsy. That would be probably, if you're working up like a TB, a pericardial effusion caused by TB or something. An EKG and a serum thyroid hormone test definitely could be either of those. Let's see. When she awoke this morning, she felt very lightheaded, so she came in for evaluation. She has no fever or chills, chest pain, or shortness of breath. But over the last several months, she has experienced weight gain, weakness, and intolerance to cold temperatures. Vital signs include BP 96/56, heart rate 48, and oxygen saturation 100% on room air. On physical exam, her hair appears brittle, and periorbital edema and swelling in the neck are noted. Lungs are clear to auscultation. Cardiac exam is normal. So, I think probably what they're saying is she has a pericardial effusion. And so you're thinking, okay, maybe we need to get an EKG to, see electrical alternans or something like that. But that's not going to help you establish the cause of the chest x-ray finding. What really is, kind of showing up for me here is she's hypotensive, she's bradycardic, she's got brittle hair, cold intolerance. This is all screaming hypothyroidism. And if you have very severe hypothyroidism, it can cause literally anything, including potentially a pericardial effusion. So in this case, I think the diagnostic test would definitely be a serum TSH, and we are right, 89%. So again, pericardial biopsy has a role in the diagnostic workup of pericardial effusion, particularly in the case of suspected tuberculous effusions. However, the weight of evidence favors hypothyroidism as the most likely cause. All right, one question down. Let's move on to the next question. A 36-year-old woman presents to the clinic for evaluation. She was referred by her dentist for clearance prior to a root canal procedure. Oh, awesome. This is what my wife does. She does root canals, so this is perfect. I hope I get this question right. With Valsalva, the click occurs earlier and the intensity of the murmur increases. The remainder of the exam is normal. Which of the following is the most appropriate treatment plan for this patient in preparation for the dental procedure? So Valsalva increasing the click and increasing the intensity of the murmur. I always have to think through my, which maneuvers increase the intensity of murmurs and things like that. Just going off of her history alone, she's 36 years old. Most likely she's going to have mitral valve prolapse, and mitral valve prolapse causes a little, click. And then I had to remember, so Valsalva would decrease preload, and that would probably cause the mitral valve prolapse to occur earlier. Again, this is something I have to review a little bit, but I'm pretty sure with decreased preload, the mitral valve prolapse murmur would get a little bit worse. And the question is, does a patient need antibiotic prophylaxis if they have mitral valve prolapse? And the answer to that is no. As far as I'm aware, really, it's if they've had a history of endocarditis or if they have, a valve replacement, aortic valve replacement or mitral valve replacement, things like that. So anyways, clindamycin, cefazolin, antibiotic prophylaxis, amoxicillin, azithromycin. So knowing from what my wife typically prescribes, we see azithromycin and amoxicillin the most commonly. Not, clindamycin more for like if they can't take these for any other reason. I've never really seen anybody get IV cefazolin or an IV antibiotic before a dental procedure. But I'm definitely thinking no antibiotic prophylaxis here. The patient denies any symptoms, including lightheadedness, dizziness, palpitations, and fainting. She reports being physically active and runs 3 miles several days per week with no limitations. Medical history is notable for heart murmur diagnosed in childhood, again, which is reassuring. This is a chronic thing that she's had. She cannot recall any other details. She denies any prior surgeries. Currently, she takes no medications. She has an allergy to penicillin. Okay, so that would make amoxicillin less likely, so we'd probably be thinking of Zithro if she was going to get antibiotic prophylaxis. But anyways, she's well appearing. She has a mid-systolic click followed by a late systolic murmur. So mid-systolic click followed by... I still believe that's consistent with mitral valve prolapse. With mitral stenosis, you get a diastolic. You get an opening snap with a diastolic murmur. And so again, this is probably all mitral valve prolapse. So let's do no antibiotic prophylaxis. 83% of people got this right. And the guidelines for infective endocarditis prophylaxis are valve repair or replacement, previous history of infectious endocarditis, unrepaired cyanotic congenital heart disease, and then repair, in the recent 6 months and things like that. And I can just actually pull up my Anki and see if I have anything for mitral valve prolapse. Just as a quick review. Yeah, so a heart murmur with a mid-systolic click is consistent with mitral valve prolapse, followed by a late systolic murmur. So exactly how they described it here. All right, next question. Let's move on to a 45-year-old woman presenting to the outpatient clinic reporting spontaneous bruising on her arms and legs for the past 2 weeks. A very interesting presentation here. A peripheral blood smear reveals markedly diminished platelets with occasional large platelets and no abnormal cells. So markedly diminished platelets, immediately I'm thinking of something like ITP, which typically presents in people who are a little younger, but ITP is kind of this autoimmune process by which you start to get thrombocytopenia from antibodies against your platelets. And then the occasional large platelets, there's some other kind of qualitative platelet disorders like Glanzmann thrombasthenia, and there's some other one that I don't remember the name of. Bernard Soulier, actually, I think it's what it's called. I've never seen any of those. I feel like they're probably more pediatric diagnoses or very rare hematologic diagnoses. So probably the large platelets is just a reflection of the bone marrow trying to produce more platelets. So her white count is 6,000. Her hemoglobin is 14.2, platelets 22,000. And then her PT, PTT, and D-dimer are pretty much normal. So really, it's an isolated thrombocytopenia. So again, this is really making me think of potentially ITP. Which of the following is the most likely diagnosis? Chronic liver disease, very unlikely in a 45-year-old woman. And she's also got normal coagulation, studies here. Typically, you would see an elevation in the PT if they have, bad liver disease. Myelodysplastic syndrome, again, very, very rare for a 45-year-old to have myelodysplastic syndrome. Typically, you're going to see that in people who are like over the age of 70. DIC, is she like super septic? Do we see schistocytes? No, we have no reason for her to be in DIC. Pregnancy can also cause DIC, but she's not sick that she'd be in DIC. You'd also be seeing clotting. You'd be seeing anemia. So very not suggestive at that point. And then now we've got immune thrombocytopenia, ITP. So this is definitely what I'm thinking right now, as I mentioned. And then there's TTP. So TTP is going to be much more serious than ITP. TTP, typically you're going to see pretty severe thrombocytopenia with a more mild elevation in your creatinine compared to HUS. Let me double check that I actually said that correctly. TTP, HUS. So TTP has very low platelets, around 10, with a mildly elevated creatinine. And this is an emergency. They would need to undergo plasmapheresis. And then HUS, again, an emergency that you would need to consider plasmapheresis. So the only problem with ITP is it is a diagnosis of exclusion. So first of all, we have to really make sure that everything else, checks out and we don't have any other alarm symptoms here. So she explains she has never had this much bruising before, and it's not as if I'm bumping into things constantly. She also mentions having noticed blood spots on her toothbrush. She denies any recent illness, medication changes, or excessive alcohol use. Only medical history is seasonal allergies. She takes cetirizine daily, unremarkable family history, vitals are normal. No hepatosplenomegaly or lymphadenopathy. So basically very benign all throughout. Benign medical history, benign physical exam. So again, we're not getting any kind of alarm symptoms. So we're going to go with ITP. And you can see 85% of people got this correct. ITP is essentially a diagnostic of exclusion, often established after other causes of thrombocytopenia have been ruled out. Giant platelets, the size of RBCs, are larger with an amorphous center, can also be seen with ITP. All right, these have been pretty quick today, so why don't we do one more question here. A 68-year-old man presents to the primary care clinic for a routine follow-up appointment. He reports feeling lightheaded occasionally when standing up over the past 2 months. So immediately I'm thinking, okay, maybe this is going to be a question trying to get us to think about syncope. So we think about orthostatic hypotension, autonomic dysfunction. We can think of vasovagal if he's like having syncopal events, and then cardiac syncope is the main thing that we have to like really rule out. So his blood pressure 140/85 while sitting and drops to 110/70. So that's diagnostic for orthostatic hypotension. As long as, and again, the criteria is greater than 20 drop in your systolic blood pressure when standing, or greater than 10 drop in your diastolic pressure when standing. And his heart rate increases from 72 to 80, which is a little bit low. You would probably expect a little bit more of a heart rate response to your blood pressure dropping so dramatically. So it almost makes me wonder if he's on a beta blocker or something that's preventing his heart rate from having an appropriate chronotropic response is what they call it. But it looks like he's not on a beta blocker. And then lab results are shown. Everything looks normal. He's got a pretty significant bump in his creatinine, but he could have CKD, in which he does, CKD. And then his hemoglobin, his hematocrit is relatively okay. EKG is here, and it looks like he's probably got some prolongation of his PR interval, very mild potentially, but just going through this systematically, he's got some extra beats here, like an extra PAC right here. You can tell it's a PAC because it still has a normal QRS morphology, but you don't have that P wave. And then contrast that with a PVC, which would have a wide and bizarre QRS. And so that would be a PVC. Otherwise, it looks like it's normal sinus rhythm. You see a P wave upright in lead 2 and a QRS upright in lead 2, and a P wave before every QRS, except for the PAC here. And then his rate is, let's see, 1, 2, 3, 4. So 300 divided by 4, 75 beats per minute. His axis is normal, so he's upright in both lead 1 and lead 2. And then in terms of the PR, we already talked about this. I probably should have just gone through this systematically at the start, but his PR is mildly prolonged, so he's got like a first degree AV block. And then, ST changes, he's got upright STs, all his T wave, there's no signs of T wave inversions or ischemia or anything like that. Which of the following poses the greatest risk for syncope in this patient? Ischemic stroke, anemia, diabetes, aortic stenosis, and cardiac conduction disturbance. Interesting. I think I'd have to read a little bit more into the rest of the question stem, because we're pretty confident, like this is a fairly benign looking EKG. And he's very orthostatic. So I'm probably thinking they're trying to go for anemia here. But I have to actually figure out what they're trying to ask here. If you think of cardiac conduction disturbance, I'd be thinking, okay, maybe we see like a second degree AV block, type 1 or type 2. That would be more concerning. Aortic stenosis, I'd be expecting to see signs of left ventricular hypertrophy. So very deep S waves in lead V1 and V2, and very tall R waves in V5, V6, or an elevated R wave in AVL. And then there's finally the Cornell criteria, which looks at AVL and V3. Diabetes, that causes autonomic dysfunction. If you have very poorly controlled diabetes, that could cause autonomic dysfunction where you're presenting with orthostatic hypotension. So that's definitely a thing. And yeah, the anemia actually probably less likely. He's not that anemic. His hemoglobin's 13. He's like barely anemic. And then ischemic stroke, this doesn't sound like a stroke to me. He denies shortness of breath, fainting, palpitations, muscle weakness, and bleeding. He has a past medical history of long-standing type 2 diabetes. Again, I'm thinking more diabetes at this point. Hypertension, CKD, and an ischemic stroke. His family history is significant for his father having CAD and his mother with hypertension. He smoked, he drinks. He has no known drug allergies. He's on aspirin, metformin, lisinopril, and atorvastatin. Blood pressure we discussed. Heart rate did not increase, as we discussed, which again to me is signaling possible autonomic dysfunction. He's alert and oriented. His has a grade 2 out of 6 systolic murmur, and then he has carotid pulses of 2+ bilaterally. So they're giving you a lot of things that could potentially be leading to his lightheadedness. They're trying to give you kind of distractors and possible red herrings, like this grade 2 out of 6 systolic murmur. Immediately, you're thinking, okay, maybe it is the aortic stenosis or things like that. But again, we're not seeing any signs of LVH here. And it's not screaming that to me. To me, the fact that he has positive orthostatics and he has a minimal increase in his heart rate from only 72 to 80 really does seem like autonomic dysfunction to me, which could be in the case of his longstanding type 2 diabetes. So I'm going to go with type 2 diabetes. And the answer is correct. And 77% of people chose that answer. So I like reading the explanation just to double check that my thought process was correct. So diabetes increases his risk of neurogenic syncope due to orthostatic hypotension. Ischemic stroke does not explain orthostatic hypotension or increased risk of syncope. He does have a murmur consistent with aortic stenosis. However, he does not have any indication that his aortic stenosis is severe, such as a loud murmur with a soft S2 and delayed and diminished carotid pulse. Anemia is just mild, so very unlikely. And then cardiac conduction disturbance would be things that are more concerning, like second degree AV block, type 2 and Mobitz type 2 and third degree AV block. However, this patient just has sinus arrhythmia and a first degree AV block. So again, not concerning to be the cause of his lightheadedness and possible syncope or pre-syncope. All right, and that is it for our questions today. Again, we're doing pretty good. Like I said, the first time I did this, I did 3 questions and I think I got 2 of them wrong. So far, we've had a pretty good track record, at least the times while I've been recording. We'll have to see how long that holds up, because at some point I'm going to make some dumb errors and get some questions wrong that I really shouldn't have. But thank you guys for joining me on this board review question day again. Hope you guys enjoyed the nice weather outside. I'll see you guys in the next video, and peace.